Now, okay. Hi, everyone, and welcome back to another session. Today, we are joined by Dr. Muhammad, who will be telling us more about general and cosmetic dentistry. The floor is all yours, Dr. Muhammad.
Hi, everyone. Thank you so much for organizing this awesome initiative for dental students. I'm super excited to be here, and I'll just jump right into the presentation. So if I can get it to move, that would be nice. Oh, there we go. I just click on it. Okay, so just a little intro and about my own journey to becoming a general dentist. And I do a lot of cosmetic dentistry. I'm also a cosmetic dentist. So this pictures speak 1,000 words, right? So this picture of me when I was in second grade is the reason I became a dentist. I had lots of dentists who were my role models as a kid. I had, as you can see in the photo, I had buck teeth, and I did get, pet names like Bugsy and Deer, and then eventually I needed braces. I was the only one of my 4 siblings that my parents decided to invest in to get braces because I was the only one that really needed it, as you can see. So that was my experience as a patient myself as a child. And I actually had great dentists that were actually role models. And my orthodontist was a female dentist, and that was inspirational to me at that time. I grew up in the 80s, so it wasn't that common back then. And my mom is also a woman who was a physician, and I loved the medical field because of my experience seeing her as a doctor who actually owned her own clinic or ran her own clinic, and how that was like a great way to have a career and also have a family. And also, everybody, I think most dentists say this about choosing dentistry because we like the lifestyle. You can choose your own hours most of the time, and you don't have to be on call. And you can do private practice a little more easily. And yeah, so all of those benefits of being a dentist are kind of why I chose this path. I never actually wanted to be a physician. Even though my mom was a physician and I admired her, I didn't like the idea of having to go through the extensive schooling and also, training after schooling. I was impatient and wanted to get going. And you'll see as I continue my introduction that I never did a residency, because that's another benefit of dentistry. You can actually practice right out of dental school. So I'm from Chelmsford, Massachusetts. I applied to accelerated dental programs right out of high school. I don't know if they still exist. I should have done some research to let you guys know, but back 15 years ago, when I graduated dental school 15 years ago in 2005. So I guess this was before that. There was accelerated dental programs, and since I knew what I wanted to do, I decided to just apply out of high school, and I decided to attend the Boston University 7-year accelerated dental program. I was actually the only graduating person in that class who got accepted. I think there were some other people that decided to do something else. But again, I just kind of knew from childhood, from my experience, that this is what I wanted to do. And so I was happy that I got in then, and I had just like a set career path in front of me. And I know different people go through different avenues to eventually become a dentist, and that's whatever works for you. I did know that I wanted to do this from the get-go, and so it worked out that way for me. So I did graduate from BU Dental School in 2005. I didn't do a GPR or a residency. I decided to practice right out of dental school because, like I said, I was kind of impatient. I wanted to start my career, start making money, and not have to do extensive things. And you can do that. That is one of the benefits of dentistry. So my first job was in a very busy Medicaid office in Massachusetts for about 2 years. And that is actually a great way to gain a lot of experience. It's usually Medicaid offices are very busy environments, meaning you see a lot of patients, high volume, and you can do all ranges of dentistry, all phases of dentistry. So there's, I learned some of the very, extensive procedures like extractions, full mouth extractions, several different multiple root canals. And it's a good way out of school to really get volume and get your hands wet, so to speak, because in dental school, you do learn a lot. You have, your simulations, your dummies, we used to call them. I don't know if they call them that anymore, where you work on the fake people, and then you work on actual people, but it is limited. And so, that's what residency is for too. That's a great way to do it. But this is a way that I ended up getting a lot of experience, was working in a Medicaid office. I continued doing associateships at private offices after that for about 2 years. I'm sorry, so the Medicaid office was 2 years, and then associateships continued on for 8 years. And after 8 years, I decided to open my own practice. I moved from Massachusetts to New York, and I decided to open my own practice. And so now it's been 8 years since I opened my practice. And yeah, time has just flown by, and it's been a great experience for me, and I still love dentistry. So my advice for pre-dental students is that dentistry is a great career. It's a great field. It's always growing. It's very rewarding. Take your time deciding. If you don't know what you want to do, this, again, great initiatives like this one are a great way to see if this is something that you're interested in. During high school, I knew, like I said, I kind of knew what I wanted to do. So I went up to the random neighborhood dentist, and I said, I want to shadow. And that's just like the best way to figure out if you like it. And, I just loved the feeling of the dental office. Like back then there were files, and I wasn't paid. I just had to find the charts, and then slowly, you, as somebody who's shadowing, you start to observe the dentist, and you see how it works. And just being in that environment and seeing dentists talk about their career or talk to patients is really helpful. So, again, thanks for having this initiative for prospective students. And it is what, most dentists do, or any career. It's great to shadow and to be in that environment yourself to figure out if it's the right feeling for you. I would say the most important part of dentistry has everything to do with relationships and people. If you love to interact with people and to get to know them over time, if you love the neighborhood feel, this is the career for you. Dentistry is unique, and dentists are unique that we really, I guess pediatricians are the same too. You really see people frequently and you see how they grow, but we get that for adults too. Even, I'm bad. Most medical professionals are bad about taking care of themselves. I haven't seen my PCP in too long. But dentists, for some reason, once you have a dentist that you found and you like you keep going, and it's more frequent than every year, because we're using our mouth all the time, and people see that, they don't want to wait till things break down. Of course, people do wait till things break down. But what I'm saying is it's dentistry, and dentists have the opportunity to see people over time frequently and kind of grow with them and really get to know the community and the neighborhood, more so than any other type of doctor, I would argue. So I would say that's like really, if you want to know what dentistry is about, the bottom line is that's what it's really about, being in a relationship with patients for a long period of time. And if that's something that appeals to you, then it's probably a really great field for you. I was just, talking, and I forgot to add this to the last slide, but I'll say it. I was talking to like a specialist, and sometimes we, as I work with specialists all the time with different cases. And we were just talking about like one implant that was a very difficult case. And he was saying that like, don't ever like, let's not touch this one. This is like a very difficult thing. And so we start talking about teeth and we forget they're attached to like a body and a person. And so I think that's really important that, we get very technical as medical people, and we like get very staunch in like our research and our literature. But at the end of the day, you're treating a person. And like the most important thing is like listening to the person and really meeting their needs and seeing what their complaints are. So I would say the next most important thing as advice that I would give is having a good business sense, which is something that you don't learn in dental school, really. I think maybe things are changing now, but when I went to dental school more than 15 years ago, we didn't really learn too much about that. So knowing, and I think things are changing now in terms of like, corporate dentistry and DSOs, you don't really have to be that involved in the business, but I would argue that you still should have like a good understanding of the business of dentistry if you want to be compensated fairly, and if you want to know what it means to be able to meet like because even if you work for corporate, they're still going to pressure you to produce a certain amount and all that. So having getting beyond just the clinical part is important to understand, because we are, even if you're in a corporate or if you have a private office or if you're a hospital based, all of those are actually still private businesses, right? So we don't get discount on our rent. The DSOs don't get discount on the rent. You still have to make money, even though you're a healthcare provider. So that's one piece of advice that I would give dental students is like, yes, you have to learn all the clinical stuff, but at the end of the day, it's a business. Unfortunately, it's not like we are funded by the government. Unfortunately, we're not. I wish it was that way, but that is a whole part of medicine and dentistry that we are under educated on. And I would say a sustainable lifestyle too. So yeah. And so the dental skills and dental expertise, like I know that's all when we're in dental school and we're preparing for dental school, we're really focused on that. They don't come at the end of dental school. That's just the beginning. They come with practice, with patience, and with time, and with continued learning. Instagram has tons of amazing dentists with great dental schools, but I guarantee you they're still learning, and if they aren't still learning, then they're probably making things up, or they're not completely real. So never think that you're going to know everything. You never know everything, especially with all of the great technology that comes out every day. Every time we go to a convention or a conference, there's some new technology, and so it's a continued process that you'll always be learning. So what is general and cosmetic dentistry? So general dentistry, for me, my personal definition, starts with a comprehensive exam and treatment plan. So that's when you first meet the patient, and you get to know the actual person a little bit, which is really important. And then you examine everything. So starting from the joints, the muscles, the teeth, the gums, the whole thing. It's not just the teeth, right? It's a whole system that works together. So it's a comprehensive exam. And so general dentistry also includes all phases of treatment, from prevention to cleanings to fillings to root canals to crowns to orthodontics. So that's another great feature of being a dentist. As a general dentist, you can actually do everything. So it's unlike, we do have specialists, of course. We have root canal specialists, endodontists, we have gum specialists, periodontists, we have orthodontists that specialize in removing the teeth. But as a general dentist, you can, under your license, you can actually do a whole range of things. Of course, check your state board and make sure you're practicing within your license. But generally speaking, you will never get bored. And most dentists, I would say, after a certain amount of time, they find what their niche is, what they're interested in, and they kind of end up focusing, like you'll see some of the things I like to do and I'm good at, that's what I will do. And you should work with specialists. Never don't work with specialists, because there's always a time that you will need good specialists on your team, in your repertoire to collaborate with. But it is an amazing thing that you will actually never get bored as a general dentist, because there'll always be new things. You're never doing just one thing all day long, unless you want to. And then the other part of general dentistry is that the goal is to get patients into maintainable health and returning regularly for recare, hygiene, and checkup. So once you're done any active treatment, the goal is that they should continue to return to maintain that healthy state, right? For monitoring every 6 months, because this is the part of the body that is, I would say, the fastest changing, because we're fully using it. It's the most active part of the body, if you really think about it. So it's not like, you see a patient, you finish with them and you never see them again. Their general dentistry is you're really seeing them regularly. And that differentiates general dentistry from most of the other specialties too. So like an oral surgeon, they'll take out your wisdom teeth and then you never see that oral surgeon again until you have kids and you send your kids to that oral surgeon. But in general dentistry, you're really seeing patients every 6 months, maybe even more frequently, every 3 months for some people who need a more frequent recare or cleaning. So for cosmetic dentistry, my personal definition is that establishing proper arch form and aesthetic result through addressing tooth and jaw position, as well as tooth appearance. So some of my cases that I'm going to show will kind of touch on this. This is not a definition from, you can Google cosmetic dentistry and there'll be a definition from the American Academy of Cosmetic Dentistry. But, this is what I practice in my comfort level and my practice. So this picture on the left side is actually one of my cases, and the top area here, the top picture here is this patient had some chipping and tooth wear. And so we did 2 crowns on this patient. And so the key behind this was that, when I talk about proper arch form and addressing tooth and jaw position, so the key is like, why did this chipping happen in the first place? Why were basically the bottom teeth or whatever it was, there's something that was rubbing against this edge, right? So why are those edges worn away like that? And if I just put crowns on without thinking about why this happened in the first place, won't these crowns kind of chip and wear at the same time? So for cosmetic dentistry, there's always a reason why things don't look great, and addressing that is really important to have a long-lasting result. Because like I said, in my practice, I see patients I've been there for 8 years, and my patients have been coming back for 8 years. I mean, some of them, of course, move away and there's always new patients, but I love seeing patients over time. And, that's maybe not for everybody either. Some dentists might not like that. They might want to just, do something and never see it again. But for me, it's really important for my work to last and to satisfy the patient and for them to get the value for what they paid for. Mm-hmm. So my day, I got a typical day in my life as a dentist. So I get to my office about 8:30 a.m. after school drop off and all the morning things. I have 3 children, age 13, 10, and 3. So I wish I had earlier hours and had the energy to wake up earlier, but right now that's the deal. School drop off and then get there at 8:30. I see patients Monday through Thursday. Patients start coming in at 9 a.m. and the last patient ends at 5 p.m. So Monday through Thursday, and then Fridays I reserve for personal time, for doing some business development and managing, the business growth and all of those parameters. During the day, I'm always in constant communication with my team. Before the day we meet, before patients come in, during, each patient block, we're always communicating, and whenever needed in between. I have 3 operatories in my office, and 2 of the operatories are full with hygiene appointments, which is a hygienist has an hour block. Usually in my office, we have an hour block for each hygienist, and they bring the patient in, they take x-rays on the patient, they usually do the cleaning, and then they call me in within that hour block. So 2 hygienists are always pulling me apart from my patient that I have in my chair. So that is something that you'll see if you ever, hopefully, things are opening up and you get to go into a dental office, you'll see that we're working on a patient and then a hygienist is telling me to come here and another hygienist is coming. So that's one thing that we do juggle usually. In the beginning, when I opened my office, I did all my cleanings myself. I opened the office from scratch, and that means we had 0 patients in the beginning. And so I didn't have hygienists. I would do everything myself. So that's also a great thing about opening your own office or being a dentist. You can do cleanings if you want to, especially right out of dental school. It's a great way to really focus on the teeth and see every area around the tooth. Sometimes I don't see things during my exam because I'm in a rush or whatever, and my hygienists will say, oh, I saw that there. Can you check that again? Because you literally are looking at all the surfaces when you're cleaning, because you're cleaning around the gum on each surface. So that's typically what I kind of have to really juggle every day. And usually we have 1 to 2 new patients every day, either a new patient that's coming in for a regular exam or sometimes emergency new patients that come in. So today, for example, we had an emergency new patient. Her mom was actually a patient before her who had dentures that had broken. And so she was an emergency patient a couple months ago. And then the daughter hadn't been to the dentist in forever. And she had a bridge that broke, and she came in and we squeezed her in, and we were able to see her. So it's just, we have a lot of families. We actually have generations that come to the office. We have the mom and then the daughter and then the grandkids of the mom. So it's really nice. I really enjoy that. That's what really makes dentistry special to me. So what kinds of complaints do patients present with? So I want a cleaning is a very common one. I haven't been to the dentist in X years, and sometimes people haven't been to the dentist in 10 years. And some of those patients just need a cleaning and they're good. Some of them are a wreck. So you see a whole range of things. I broke my tooth and my tooth chips. A patient today was just pulling up an article for me. I think it's in the Times about how there's so much more chipping and grinding and stress because of the pandemic, apparently. It's true. We see a lot more complaints about jaw pain, teeth chipping and fracturing since the pandemic has started. I have a toothache. So a lot of times people, even, again, related to the pandemic, people haven't been to the dentist in a long time. There's a cavity that's been growing in there, and then you eventually get a toothache, or a broken tooth can cause a toothache too. So that's a pretty common complaint. My teeth are sensitive. A lot of people have sensitive teeth. Either they're worn down or their gums have receded, and that can make your teeth sensitive. My gums bleed. Again, if you haven't had a cleaning in 10 years, your gums probably will bleed when you brush them. My jaw hurts. That's a big one. A lot of people with muscle pain, joint pain. I grind my teeth. I live in New York. I'm from Brooklyn, but my practice is in Brooklyn. I don't think I mentioned that or put that in there. New York City, like everybody here grinds their teeth. I think probably all over the world now, but that's a big one. My teeth are crooked. A lot of people are more conscious about their teeth, maybe because of Zoom, or I don't know, but we're doing a ton of Invisalign at my office, and it's really not me, quote, selling it, or it's because people notice it more. But also, what I'm learning as a constant learning process that I do is that crooked teeth are actually more easily stained, more easily build up plaque, which is the bacteria film, more easily grow tartar, which is the hardened plaque, and also cause bite discrepancies. And usually when your teeth are crowded, it means that there's a bite unevenness, or there's a reason that they're crowded. So that's something that I've been learning more about more recently. My teeth are yellow is a big one. People love white teeth. People love teeth whitening. And my teeth are worn down. Again, that's like an end result of grinding or your bite being uneven. Teeth can wear down over time. I always say to patients, we see less and less actual cavities or like acute disease. We still see a bunch of that, but a lot of people have a more, what I like to coin, chronic problem, which is the underlying bite issue, or you're grinding your teeth and you're wearing it away. So it's not something that needs to be addressed right now. Just like a filling or a gum disease or a cavity has to be done like in the next couple of weeks. These types of things where your teeth are slowly chipping and wearing down, they don't have to be addressed tomorrow because it's happening slowly. But I tell patients, what do you want to deal with when you're 70 or 80? Do you want to deal with your worn down teeth then and get dentures, or do you want to, address the root cause of why you're wearing it down now so that you don't have to worry about it? And we do see, like I said, we see different age groups, and a lot of the older patients, they don't have a ton of decay, but their bite has been deep for 70 years and they're finally just knocking their teeth out because of the deep bite. So these are things that, for me, my training in dental school, we were taught to just treat like the acute problems, like big cavities. And I think medicine is like that. And even physicians, like we, I think in dentistry a little bit more, we talk about preventative, but not this chronic wearing of teeth. Like that is a very common thing that should be more, we should learn more about it. And I think it's also a newer phenomenon because we all lost our teeth, like our parents' generation, right? They didn't have teeth that lasted that long. But now that we do have prevention and we're getting less cavities, our teeth are actually there when we're 70. But now we're shifting to how to make them last in the position that they're in, right? In the proper bite, so that you're not dealing with huge cavities when you're 70, but you're dealing with teeth that are worn down, and that can be painful also, and that can be detrimental to chewing and function at that point in time. So what kinds of procedures do general and cosmetic dentists perform? So I think I mentioned before that the comprehensive exam is, to me, it's like very important. I really put a lot of time and effort, and I've developed my comprehensive exam that I do in my office over the years. So I do have, extra training in how to palpate the joints, the TMJ, which is the temporomandibular joint. And it's a very complex joint, I tell patients too. It's the only joint that's crosses the midline, right? We have any other joint in the body that there's a bone that crosses the midline, maybe the pelvis, right? But this joint has a hinge, and it can open and close, and it can also slide forward and backwards. A very complex joint. There's a disc behind the joint, and there's muscles that connect the top and bottom jaws that connect the lower mandible to the maxilla. And it's all connected, and the bite is also connected to that. So it's very complex, and there can be a lot of different issues with it. Clicking and popping is one, pain is another one, deviations, like if your jaw doesn't open properly, people get their jaws locked, closed, or they're unable to open really wide. We had a patient this week that he couldn't open enough for x-rays. And so there's a whole host of things that can be wrong with your joints, your muscles. And then a soft tissue exam is very important too. So pulling back the lips and checking everything inside what we call the vestibule, which is like this little gap between, or this little fold between the lip and the top of the gums. Checking all of that, checking the cheeks for anything that you see that is out of the ordinary. And of course, you'll get a lot of training in this in dental school. And then checking the gingiva, which is the term for gums, right? So we use, I think the next slide talks about some instruments that we use for that, but that's one thing that's important. And then the new buzzword in dentistry is airway. So, and that's very connected to the mouth and the teeth because, and I'll show some photos of what to examine in an airway in a little bit, but basically the lower 2/3 of your skull is the part of the skull that has the teeth, right? The maxilla and the mandible. And that is actually the front of the airway. The airway is, you know, the trachea and the area basically that's here, right? Between the jaws and the spine. So sometimes we see problems with the airway because your jaws are too far back or your posture is too far back or forward. So, you know, there is a lot of new information and it's a very hot topic. And I've been kind of obsessed with it for the last few years since I heard about it in continuing education. And it's something that's really interesting. And it is, I think in the next 5 to 10 years, every dentist and hopefully in dental school, they're going to be really focusing on this because it is we're finding out it's one of like the root issues behind things that we see in the mouth every day in private or in practice as dentists. So for example, we see sometimes people with rampant decay or teeth that look like they're very dried out or a mouth that is kind of just, you'll see when you're looking at different mouths, like some mouths look normal and some mouths just look completely out of whack. And it's probably because your airway is compromised and you're breathing more through your mouth. And so these things are just really interesting. And you can follow some of these great dentists on Instagram. I think Ask the Dentist is one of them, Mark Burhern. And it's just when you start learning about these things, you really start to connect the dots, especially somebody like me. Like, again, I like to get to the root of the problem and I like to see patients over time. And so this is an important piece to me to help patients establish overall health. So I'll talk more about it. You can tell I'm obsessed with it. And then finally, after you do all of that, then you get to the teeth. So dentistry is not just about the teeth. The teeth are, you know, it's part of the person, like I said. If we just focus on the teeth, which I did since dental school up to about, I would say, you know, 2-3 years ago, just obsessed with the teeth because I didn't think there was much more beyond that. But there is much more beyond that. So after you do all of that, then, or after I do, this is my comprehensive exam. So after I do all of that, then I look at the teeth and I look at cavities and all of that. And then also, of course, the bite. So other procedures that I do in the comprehensive exam, or my hygienists help do, is a digital scan, which is, you can see we have an iTero machine in the office. We love it because patients love it too, because you don't have to take a physical mold with, when you mix the alginate, it's like a powder and liquid, and you whip it together, and then you put it in like a tray that's shaped like a horseshoe and supposed to fit in your mouth. And then you like stuff it in there and you get a mold. And actually, I loved that when I was a kid. I was a weirdo. That's why I became a dentist, because I thought it was the coolest thing. Like, they took a mold and they could see my teeth. It reminded me of making popsicles. Like, you have the mold and you pour something in and then you take it out and it's the shape of the mold. So it was cool. But now we don't have to do it with a putty. We take our little magic wand here. We wave it around the mouth and the patients ooh and ah, and they're like, oh, wow, look, I can see myself. And so you can blow it up, you can, rotate it and look at details, and you press these little buttons and it shows you the bite, and you can see if the bite's even or not in the flash of an eye. So it's really cool stuff. I call it video games for dentists. So we also oversee the hygienist. Like I said, that's a pretty important part of general dentistry. And, the hygienists, if you have a practice that has hygienists, they do all the prophies, which is short for prophylaxis, which is another word for prevention. It's a preventative cleaning that you get every 6 months. And scalings. So scalings are when somebody has gum disease. So I'm going to do my little spiel for you that I do for my patients. So pretend my fist is your tooth, the part of the tooth that you can see, okay? And my sleeve is the gum, okay? And my arm is the root of your tooth. You can't see the root of the tooth because it's covered by the gum. So when this gum is in the right position, it's about, let me fix my sleeve. This little gum line is called the gingival margin. The gum line is about 3 millimeters free from the root of the tooth. So if I put a little probe in here, it should go in and it should stop at 3 millimeters. If it goes further than 3 millimeters, it means the gum is not attached to the root anymore. And that means there's inflammation. Either bacteria has been sitting under there and the gum is still there. It's not receded. Gum recession is different when your gum moves down, right? And then you can actually see the root. This is different. This is called pocketing. The gum is still there. It's just not attached. It's loose from the root. So the probe will go down deeper. And that's, again, caused by bacteria that's been sitting there. You haven't had a cleaning in so long, or, some people just genetically, they're more prone to that, or people who just never floss and brush and there's gunk sitting in the gum line. So that's when, if you have deeper pockets, so 3s and 2 millimeters, we go around and we measure around each tooth, 6 points of measurement. So 3, 2, 3, 3, 2, 3. We measure that and we chart it in a nice chart with every tooth. If we see multiple areas where it goes down 4s, 5s, we've seen 6s, 7s, and 8s, 9s, 10s. That means the gum is still there, but it's loose all the way to here. So the tooth doesn't have any bone surrounding it. So the gum also has bone under it, right? So if it gets to the point where you're beyond like 5, 6, 7 millimeters, that means the bone is also, there's bone loss there, and your teeth are there, but they're loose and flapping in the wind. So scaling is when it's you have multiple areas where there's deeper reading. So that's called periodontal pocketing, anything a 4 millimeter or above in multiple areas. And then you need something called a deep cleaning or a scaling. So that's when we give you some Novocaine. We do one side at a time so we can take our time and do a good job. And we go down with some instruments into that gum line where it's loose, and you wash out all of that inflammation. You wash out all of the bacteria that's in there. And that way the gum actually gets healthier and it will actually reattach sometimes. Usually doesn't reattach fully. And if you've lost bone, the bone won't grow back unless you see a specialist and you get bone grafting, or other laser is a great way to address that and can actually stimulate growth. So that's something general dentists do. We screen for periodontal pocketing for every patient, and we see if they need just a regular cleaning. If they have all the readings are, the periodontal probings are all 2s and 3s, maybe a couple 4s, 5s, you just need a prophy. If those readings are beyond 4 and 5 in multiple areas, then you may need one. So we call these quadrants: the upper right quadrant, upper left quadrant, lower left, and lower right quadrant. So you might need 2 quadrants of scaling or deep cleaning. So that's another thing general dentists do. We also do fillings, crowns, root canals. These are things that I do in my office every day. They're routine. Implants, I do place implants in my office. I did training in that at Columbia. They have a continuum, dental implant continuum that's like 99 hours. So I did that back in 2012, right before I opened my office. And I love placing implants. I don't do like crazy big cases, but I do single implants, usually sometimes 2 in a row. And so there's a whole range of different implants that can be done. And there's more difficult ones that involve like sinus lifts and things like that. But I do pretty simple implants. Invisalign and expansion. This I do a lot in my practice, because again, I do see that things are not usually in the right place. And I am already at 7:42. I'm sorry, I'm taking like so long. So bite analysis, bondings, veneers, gingivectomies, which is removing some of the gum. So I'm gonna kind of hurry up because I'm taking too long. So diagnosis, what kind of tests and instruments do I use? I think it's really important, again, to greet your patient, to introduce yourself. And that's like the first step in establishing that relationship, to see what your patient wants, what their complaints are, what their expectations are. So getting a good history and a history of the complaint itself is great. I think I already talked about the perio probe. Diagnostic casts are, yes, that mold you take, or you can do a digital one. Photography is really important. Hopefully I'll show you some of my photos coming up in the cases. Diagnostic wax up is when the lab or dentists do themselves can put some wax on a model of teeth to see what the proper proportions will be. You can do that digitally on digital models too. You can do a digital mock-up. I use like an app called Pixelmator I take a picture of the smile, and I use that app to like draw what teeth could look like. And a laser is a great tool too. So these are some digital models that I have of teeth, just as an example. And this is the laser that I have. It's called a Precise, and we use it to recontour gum when needed. Actually, to uncover implants, it's a great tool. Then you don't need to cut the gum. You just make a little hole in the gum with this little tip. So it's great. I think this is a little video. Hopefully it plays. So this is an articulator, which is like the most annoying tool in dental school. I hated it. I was like, what do I need this for? But now I realize how important it really is if you want to see what the bite can do, and why, again, the question, why do I have wear on my teeth, or why did the teeth end up this way? So it's just, you can see how you can actually like mimic movements, the jaw movement on an actual, it's called an articulator, on an actual simulation of the teeth and the bite. So it's a great tool to see what's happening in the mouth dynamically, instead of just, photos are just one point in time, but this is great to see what can happen over time. Okay, so new technology in cosmetic and general dentistry. Again, digital scanning, when I was in dental school, it had just come out 15 years ago, and now it's pretty common. I would say, I don't know how many percent of offices have it, but it's a very common and great thing to have. CBCT is a great thing to have, even as a general dentist. I don't have one yet in my office, but I utilize it all the time. We have a service mobile van company that's called Cone Scan that actually will go to the patient's house and do the scan for me. So until I get my own, that's what I use. And it's great to see. These are the teeth here, the upper teeth and the maxilla. This is the mandible and the teeth in the mandible. And this is still the maxilla. The nose and the sinuses are part of the maxilla, right? So you can see the relationship of the teeth to the sinuses. And these blue lines I was working with a colleague of mine, and we're like, oh, look, they're missing the sinuses. The sinuses are supposed to be triangled out like this. And so there's a big chunk, and it's because they're very narrow. They didn't develop fully. So CBCTs are a great technology in dentistry. So airway, I'll talk about a little bit. What's the title of this slide? Hold on. Important terms in cosmetic dentistry. Like I was saying, it's a pretty hot topic right now. So Mallampati score is when a patient opens, how much can you see back there? So can you see their uvula? Can you see the tonsils? So a lot of people, when they open, you can actually not, in this one, this is a good Mallampati. This is Mallampati like 1 or 2. You can actually see the whole airway, the whole upper oropharynx here. So a lot of people, when they open like that, you can't see anything back there. All you see is the tongue, like all the way up here. You won't see the uvula. You won't see the pillars of the tonsils or anything. So that's a good thing to start looking at. Tonsil grade. So this is tonsil grade 2. The tonsils are hidden behind these pillars, we call them. If it was tonsil grade 3, you would see red kind of, or pink, like bulbular tissue here. If it's tonsil grade 4, it would be like the tonsils were so big, it would be covering this whole area. And then tongue is very important. I didn't learn anything about the tongue, or I don't know, maybe I wasn't paying attention, but I learned so much about the tongue in the last few years and how important it is to assess for tongue tie, because the tongue is the driving force behind craniofacial growth. So if you have a restricted tongue, then you probably didn't grow as forward and down as you were supposed to. Masseters are these muscles right here. Temporalis is the temple muscles. Pterygoids you can actually palpate them from the inside. They're the little muscles also that help open and close. Some more terms that I did some training with Spear Education, and they focus on facially generated treatment planning. So some of the work through that they do is, first you determine where the teeth are supposed to be, the aesthetics, and then the function, and then the structure, and then biology. If you think about where the teeth are supposed to be, and use these templates. So these templates are also a great tool. If you lay a template over a photo that you have of teeth, you'll kind of get an idea of where they're supposed to be. And then you can see, what you can do to get the patient there. So this picture here is of one of my Invisalign patients, and the red and the blue marks on the teeth are from something called articulating paper, which is little rectangles of paper that you have, and you can have the patient bite on it, and it actually will help you see where the bite comes together. And for this patient, we're actually doing Invisalign because he has really heavy bite on his premolars. And so the idea is to fix his arch form, to expand his arch form and line up the teeth more evenly so that he's got really severe gum abfractions or recession because of the bite being too hard. Okay, so this is my first case. Maybe I'll just be able to get through. Maybe I'll skip number 2 if you think that's a good idea. but I'll do.
Sorry, it's completely up to you. We can go a little over. It's no problem, as long as you're okay with that.
Okay, sure. So this is case number 1. The patient chief complaint. My teeth are worn down and I don't like my smile. And so this wasn't her chief complaint at her first visit. I've been seeing this patient, and this case is from, I think, like 2 years ago, when we completed this case 2 years ago. But before 2 years ago, I've been seeing this patient since pretty much I opened the office. So I've been seeing her, I would say, for 5 years before she decided to do something about her teeth. So again, it's great to build trust with patients, and I don't like to sell dentistry, and I know a lot of corporations pressure dentists to do that, and I just build value, right? So I point out what I see, and I point out like worst case scenario that can happen short term and long term. And I always say, I can't predict, but this is what I see, and this is what I've seen in other patients. And so then patients appreciate that, and they actually are invested in it, instead of like, us trying to sell it, and then they get annoyed because they have to pay all this money and like they don't like it. So for me, I love it when patients do this out of their own value, like they see the value in doing it. So again, aesthetics, function, structure, and biology. So this is how she started, right? So if you look at this picture, and then you can ask yourself, what should the teeth look like? Where should they be in space? Where should they be in the patient's face? So you start putting those templates over. Sorry, I didn't have time to put the templates on in the presentation, but these are some of the questions that you can answer with a template, or just looking at a photo and trying to figure out what's going on, what's not ideal about this smile. So is the display of the central. So the centrals are the 2 middle teeth. Is it excessive or is it inadequate? And actually, they look like they're actually not too inadequate or too excessive. They look actually pretty good. The display, how much should your front teeth show when you smile and when you're at rest? So when you're at rest, your front teeth should show about 1 millimeter. And, some people prefer more. So that's just a patient expectations that you would ask. But in, generally speaking, when your lips are at rest, should show about 1 to 2 millimeters. And when you smile, most of your teeth should show, except for the top. And again, some people might like a more gummy smile. Some people might not want, and men and women are different too. So there's a whole set of data that cosmetic dentists can look at in terms of how much do your teeth want to show, and what's normal and what is expected for your teeth to show. And then there's angulation. And in the next case, we'll talk more about that, but that's what is the angle of your teeth when you're doing your profile. Do they stick out too far, like that first picture of me? Do you have buck teeth, or are they leaning backwards, or are they at a good inclination? Is the midline center. So there's 2 midlines. There's one from the lip to the teeth, and there's one from the top teeth to the bottom teeth. So is the midline lined up to your lip and also to your face? Does the midline look, everybody's probably Googled that Tom Cruise and his midline's like off like 5 centimeters. So, that's an important question to ask when you're looking at a case. Incisal plane. So that is basically, incisal means the biting edges, right? So are the biting edges, are they following, if you put a straight line between your like across your incisals this way, incisors, is it matching up with your pupillary line? So that, is something to consider. If it's not matching up, is it acceptable? Because maybe their eyes are just off. You want, but it's important to look at it, to have a baseline before you start to, in case, you end up somewhere else and you wanted to know, you need to know where you started, basically. And then the more important part of the incisal plane is, does it follow the lower lip? So for her, for example, her lower lip is actually a little off, right? So her lower lip on this side, it goes down more. So do you actually want it to follow the lower lip in this case? Or will her lower lip change when I just change the slide here? Look at her lower lip now, and it's more even. So what we did for this patient is we actually did Invisalign. So this is before Invisalign and this is after Invisalign. And then you'll see in the next slide, we did veneers. I did veneers after Invisalign. So the next thing in that breakdown is buccal corridor. So is there space between the teeth and the corner of the lip? So this is buccal corridor. So this is the corner of the lip and these are the teeth. So if you have an ideal arch form, your teeth will actually fill this whole corridor. And it won't look weird. It won't look like you have like a weird smile, but it'll just look like you have a fully developed jaw. And so I'm telling you right now, 80% of us don't have that. We're not developing the way that we're supposed to. And that's a whole other thing that you can invest in and learn about. But is something as cosmetic dentists we look at, and a lot of cosmetic dentists actually fill that space with veneers, like we bulk it up, or you use Invisalign or braces to move the teeth to a better position, and then you can do minimal adding to those areas. So after you look at all those factors, what treatment options do you have? Can we move the teeth? Can we move the gums? Do we do a combination of both? So it's usually, or are you lucky and you don't have a problem with where the teeth are? So in this case, she actually has a lot of wear on her teeth. The teeth look like a normal they look like they're in the right positions, these centrals, because they've actually moved down. So you can see in the second picture that we actually moved this tooth as high as we could with Invisalign because it was worn down. And as it wore down, it started to, wore down, it started to shift downwards. So teeth are always moving, okay? Teeth are always trying to find each other. So if you have, basically as an example, if you have 4 wisdom teeth and you only get the 2 bottom ones extracted and you still have 2 upper wisdom teeth, it's going to take a few years, but those upper wisdom teeth are going to shift down until they start touching your lower gums, basically. It's called super eruption or compensatory eruption. The teeth don't stay. If you have a tooth that's not touching something, when you bite, it's going to slowly shift down. If you apply force to a tooth, you can shift it up. So you have basically organic orthodontistry that's happening in your mouth, orthodontics that are happening in your teeth are always shifting and flexing so that they can touch each other. So as this tooth, for whatever reason, she wore this tooth down because her bite, I don't have photos of her bite, but she had a crowding on the bottom. So there was more rubbing because of one tooth on the bottom was sticking out and it was rubbing against this top tooth. And so it wore down. Or maybe she was grinding and she would just bring her jaw forward in that one area, and that one wore away at a faster speed. So basically, again, we looked at the aesthetics and we said, okay, the aesthetics are good, but if we want her smile to be, if you want to restore the worn edge, basically the choice was either we put the veneer on this worn down tooth and, we work with that, or if we move this tooth back to a better position, if we move the teeth out to create a better arch form, we'll probably have a better result with the veneers instead of trying to work with something that's shifted over time and things have worn down over time. So kind of, again, going back to putting teeth back to where they're supposed to be. So that's kind of what we did for her. And so this was before, and then this is after Invisalign, and then this is after her veneers. So we ended up doing, I believe, 8 veneers on her. And you can see, the buccal corridor is more filled with those, and the incisal plane is more aligned with her lower teeth, and she's just really happy. And she's been returning since, and she can't stop talking about how it's made such a big difference about her smile. And she's an older lady. She decided to do this, and she's almost 70. So it's just super rewarding. That's why I love doing cosmetic work. It's one of my favorite things to do. So this is another case 2. So the patient's chief complaint was she had veneers. Actually, my veneers are old and they have some decay. So we were noticing over time, also same thing. One of my favorite patients, been seeing her for years. Her son comes to us too, super sweet lady. That's like such an important thing to actually know the patient, like to see if this is a case that you want to take on. Because honestly, there's patients that I don't really want to see. And, when I was young and naive, I would think that was like weird to not want to work on some patients and be happier to work on others. But it's true. It's a big headache when the patient isn't on the same page as you or doesn't appreciate you and all of the things that you are trying to do for them. So it's a consideration to really, work on patients that will appreciate you. So again, what should the teeth look like? So if you look here, her display, display of the centrals is a little excessive, right? And she had other issues too. I don't have pictures of it either right now, but she has wear on the back of her teeth. It's actually erosion. And so we were trying to figure out why are her teeth so eroded on the back. So we actually converted these to crowns because the back of her teeth were eroded away. So she declined, when you're in dental school, you'll learn about erosion. And the number one thing they'll talk about is bulimia, people who regurgitate their food. It's obviously a eating disorder. And so people with bulimia will have erosion. She declined any of that. And I strongly believe she has some kind of gastric issue. Again, she declined that. Her physician says she doesn't have that, but there's something that's causing erosion on the back of her teeth. So, and because of that, the teeth are actually, she's lost some of the actual tooth structure and the teeth are closing in. And if I just try to put crowns as is with her deep bite, the lower teeth would start just hitting the top teeth because you have to have room, right? You either grind off a bunch of tooth and that makes room, or for her, again, we did Invisalign so we could actually open up some space and then add material there to protect her teeth. So again, the same questions that we ask, the display of centrals, is it excessive? So here it's a little excessive because her teeth have, again, shifted. And the angulation, this is a picture of an example of what the angulation is. So as you can see in this picture on the left of the screen, that the angulation is actually a little retroclined. So it looks like her teeth are kind of leaning backwards, right? And then this on the right side is actually, I don't know what my mouse is doing. Oh, there it is. Okay. Is actually, after we had prepped her teeth, we put in what's called a mock-up. So remember those digital models? You can send those to the lab and they can print them out and you can tell them, okay, now can you please do a wax up and make the teeth more proclined? And of course, this is before we did Invisalign and this is after we did Invisalign. So things have changed because of the orthodontics, the Invisalign, the aligners. Also, we created a proclination with the aligners. But the lab can also do a wax up, which is on the model. They'll put wax to put out to do like a mock-up of what the teeth want. What we want the teeth to look like, the new crowns to look like, right? So then you can actually take that mock-up. You can make like a little plastic, we call it a stent or a template over it. And then you have like a mold, you have a template of what the wax on the model looks like, and then you can transfer it onto the teeth. without doing anything final yet, just to see if the patient likes it, if we're happy with the new size and shape and proclination and the midline, and make sure everything looks good. So that's a great thing that cosmetics dentists do. We do like a mock-up in the mouth, either with temporaries, or you can do it just like a quick mock-up. That is like, you just put some material in to see how it looks. And so this is another picture of her mock-up, and you can see the midline looks nice, and we could check, then we can take a picture of her with the mock-up in place and see if the incisal angle or the incisal plane is level with the interpupillary plane. You can check if it's level with the lower lip. And so this case, like I said, we prepped it for crowns. I wanted to show a picture of what a prep looks like and how scary it looks for dental students. So with that model that you send to the lab, there's also something called a prep guide that the lab can send back, because it's hard to grind these teeth evenly, right? And that's a really important thing, to grind these teeth down evenly, or we like to say prep. We don't ever say drill. We say prep. We prepare the teeth. We don't want to use words drill, and we don't call the instrument it's really a drill, but we call it a handpiece, right? So that we can prepare these teeth evenly and make sure that the porcelain is going to be an even thickness, and that's going to result in a better aesthetic outcome. And it's important to have smooth edges around the preps, and you have enough clearance between the top and the bottom, and use something called cord, which is like this little rope that you tuck right into that gingival margin. And what I was talking about, where there's about 2 to 3 millimeters, a normal amount of give here between the margin of the gum and the root of the tooth. So you tuck a little. So that's what this dark thing is. What you're seeing is, it's called a cord, and it basically gently just holds the gums away so that you can go right up in there. And that's really important to get a good gingival margin, because if your margin for your preps aren't all the way up there, then you're going to see the edge of the crown when you look closely. So if you put your margin right up against the gum line, then you won't see that. It'll be kind of slightly covered by the gum, which is what you want, but not too much under the gum line, because then you're going to disturb the biological width, which you'll learn about in dental school. And I'm sure DentalShadowers has awesome slides about that. I love you guys' Instagram slides. They're really informational. Yeah. So then this is kind of like the before Invisalign and her old veneers, and then after Invisalign and veneers. And you can see, I always love it when you see how patients learn how to smile. Like before, she's kind of like, smile, and she's like, but now her smile is like, her lips just, you learn how to smile when your teeth look even and they match your face. You just learn how to smile. And that happens in like every single case that is done with like this kind of workup and thought. And it takes a lot of planning and communication with the lab. But when it's done properly, you really just, it's great, because sometimes it's not like a dramatic change. And I love it when patients say, yeah, my friends didn't know that I got this, but they noticed, they were like, what did you have done? And they're like trying to figure out what the patient had done. And it's like our little secret that they had 20 veneers done. So yeah, it's really fun. Okay. So this is case number 3, and it's an implant case. And it's a case, again, this is another patient that's been in our practice for a long time. In 2014, this is the x-ray of their front tooth. Okay, so this is number 9. It's a front tooth, and there's this little weird shadow here. Actually, both his front teeth look not normal. So this is more normal looking. This is a lateral tooth, number 7. And this is the root of the tooth, and this is the canal, right? And that looks pretty normal. Then you go to this one. This is tooth number 8, and it has a root, but it has a canal that kind of stops here. You don't really see the rest of the canal. And then this one has a root and it has a canal and it actually goes all the way down, but then it has this dark shadow here. And this is called internal resorption. And most likely he had some kind of trauma to his front teeth. And that's a very common thing. You see a lot of people have trauma to their front teeth. And sometimes, it's fine. It doesn't hurt, but it shows up later, maybe 5 years later, maybe 10 years later, maybe 20 years later. And sometimes people don't remember that they had trauma. Anyway, so this is called internal resorption, and it's when the tooth starts eating itself away from the inside. It's like a little autoimmune thing happening inside the tooth, and nobody really knows why it happens. In my experience, it happens in my patients. I see it because they've either had trauma in the past or that they grind their teeth and one of them decides to eat away at itself. So internal resorption. And unfortunately, you can't really do much for internal resorption. Most of the time, the endodontist, the root canal specialist, when you should refer when you see internal resorption to see what an endodontist thinks, if it's treatable. Most of the time, they won't treat it because if you start messing with this is basically a huge hole in the root. And it's like a Pandora's box. You start touching this and it's going to blow up faster than if you didn't touch it. So the protocol for internal resorption is watch it until it starts becoming symptomatic or it starts communicating with the outside. So we watched this from 2014 until 2018. And in 2018, this x-ray was taken and we did that periodontal probing and we found that there was a huge pocket. It's finally resorbed enough that it came out. Like it was a hole that started inside the tooth and it slowly ate its way and it started communicating with the outside of the tooth. So it ate itself through the actual tooth. So at this point, we had to do something about it. So we referred to our really amazing periodontist, not in the same building as us or anything, but he's a great periodontist, Dr. Zaidel in Brooklyn, that we work extensively on many cases. So this was an implant that I wasn't comfortable doing. So with those, I refer out to different periodontists. And so we coordinated with the periodontist and made up a plan that he would need actually a crown on number 9. And in the interim, he would need, backtrack. He would need a crown on number 9 and an implant on, a crown on number 8 and an implant on number 9. Extraction, which is the removal of the tooth, and an implant, which is the titanium or sometimes zirconia screw that's placed into the bone to replace the root of the tooth that had the internal resorption that was hopeless. Nothing could be done for it. And in the interim, we made this bright white zirconia cantilever bridge. So it's a bridge that hooked onto number 8, the central incisor, and I'll show you photos in a minute, and cantilevered off so aesthetically the patient wouldn't have a missing huge hole, right, on number 9. So it looks like this, and this is temporary. It won't work long term, but until he needed the extraction, he needed bone grafting, and then he needed the implant and the healing after the implant. That takes time. It took about, I believe, 9 months. And this picture on the right, these little screws are screws that the periodontist does an amazing job. He takes autogenous bone, which is bone from your own face, either the ramus, like they harvest bone from here, or they can harvest it from your thigh, and they make a little plate and they actually tack it to the existing bone because there was a huge defect, which is when the bone is missing a chunk, basically. So you need to build it back up, because if you try to put an implant in bone that's missing a whole chunk, the implant's not going to be fully surrounded by bone, and then that's not going to work long term. Implants work by integrating into the bone. And so you need the bone to form around it. So we worked, again, we coordinated, and I made this temporary while we had to make it so that the periodontist could easily remove it to access the area for the extraction, access it for the bone grafting, access it for any follow-ups, etc. So the implant was placed by the periodontist, and then this is the impression that I took. So basically, several months later, this, you can see this on the left was still when they had the temporary. So they removed, this is the periodontist x-ray. They took off the temporary so they could place the crown. And then on the right here, I have a temporary, we finally made a temporary crown on that was separate, not a cantilever anymore. And we took an impression at the same time. So this is what an implant looks like. And this inside, the implant's actually like a 2-screw system. The outside is the part of the screw that's screwed into the bone. And then there's an inset screw in each implant, right? So that's where we can screw in anything we need as dentists, general dentists, prosthetic dentists, to articulate to the implant, to connect to the implant. So we can screw in something called an impression coping, which is you have to order the right one that's the same brand and the same size, right? And you have to have the right screwdriver, because each implant system has a different articulation, a different size and shape of the driver. Some of them are compatible to each other. For example, like Zimmer and MIS, they're compatible. So you put in this little coping, and then the lab knows what they have analog, which is like a replica of the implant. And when we screw this in and we put some putty or we do a digital scan of this area, the lab knows where it is in the jaw. And they also know what the implant looks like, because they have a replica of the implant that they put in their model that they create. And then they can actually build the crown on top of the implant. So that's how an implant case works. It sounds a lot more complicated. Once you do a few, it gets less complicated. So these are kind of his before and after. This is from 2014. This is the tooth that had the internal resorption. It actually had a veneer on it, and the gum line was a lot higher. And this is what the cantilever bridge looked like. So you can actually see my margin there, because it was a temporary, and also he had surgery, right? So if you look at my margin here, it's about more than 1 millimeter too far down from the gingiva. And that's because when they did the surgery here to place the implant, the gum actually will recede. And that's why it's important to do a temporary first, because especially if you're having surgery done or an implant placed, the gums will move around a little bit. So phasing treatment is something important. And again, coordinating with the specialist is important too. And so this is actually from the other day when he came. He actually has a little inflammation around this tooth, which is, I believe, oops, sorry, I don't know how to go backwards. Oh, there we go. So he has a little inflammation around the implant there. So I think it might be because he just had a cleaning, but we should check that and make sure the implant is not having peri-implantitis, which is inflammation around the implant. And this is the new crown. So that's his case before and after over, I guess, 7 years. Yeah. And this is the smile before and after. Well, this is actually, I believe, the cantilever. This is not before. And this is after. Okay, so my last few pieces of advice are, I didn't write this in, but I was talking about airway and how, our genetics are the same. So if you look at archaeology from 400 years ago, our jaws were a lot bigger. And that's because our softer diets and our tongue competence, we're not getting the fully grown jaws that we're supposed to. And that's actually one of the things we're discovering as dentists is the root cause behind all of these problems that we're having. It's a modern day problem to have cavities and gum disease and all of that. So that's been a great lesson for myself, because as dentists, we are very, we want to fix things. As doctors, we're fixers. That's why we go into the field, because we want to help people, right? So sometimes it's good to figure out why things are happening, so that, because naturally, again, it's the practice of dentistry. We're naturally perfectionists. We want to help people. We want to do the right thing. It's okay if everything is not perfect. And starting to learn about the reasons the teeth and mouth got to their current place in the first place it's been a great awakening for me, to think outside the box and get to the root cause. Because, there's only so much we can do. There's another bigger force sometimes, that is diet, patient genetics, the way that they form, that can interject and undo all the work the amazing work that you do as a dentist. So there's other forces that play. So you can do as much as you can, and that's a great service that you do for patients. I just love learning about why they got to that place in the first place, and what's going to happen in the next few years in terms of how much we learn about how growth and development and airway. So two accounts that I follow on Instagram that are great one is Dr. Stephen Lin, and he says there's no natural system where tooth decay occurs. So basically, humans are the only ones that have tooth decay, besides animals that are in captivity and are given like a, soft diet or a carbohydrate diet. So we're the only animals that have tooth decay. You can't, Dr. Mark Burhern, who's the Ask the Dentist functional dentist, he says you can't brush and floss your way out of a bad diet, and you can't do dentistry out of a bad diet either. So there's always, it's just been, I wanted to share that with you guys, that there's reasons behind we have such high rate of caries, that we have wear and tear. And, we're superheroes as dentists for doing the work that we do, because it's a huge amount of work that needs to be done. And that's it. That's my three-year-old there, my littlest one. And thank you guys so much. I'd love to answer questions if I didn't take too much time.
No, yes, if it's okay with you, we do have time for a few questions.
Sure.
Okay, awesome. Okay, so the first question is, I had always thought you needed to do a residency to practice in New York. Is that not the instance, since you are practicing in New York?
Yeah, so I grandfathered out of that. I don't know if the rules have changed now, but when I moved here in 2008, I had already been practicing dentistry in Massachusetts for, I guess, 3 years. And so there was a rule when I applied for my license in New York that if you've been practicing for, I believe it was 3 years, then you grandfather out of the rule of needing to do a residency. So yeah, you're right. That's a great point though. Some states do require a residency, but Massachusetts did not at the time. I don't know if it's changed now, but I'm sure there are still lots of states that don't require it, but some do.
Okay, thank you. Good to know. The next question is, what are the benefits of having your own practice opposed to your associateships?
Yeah, so I was never happy as an associate. And I think some of it had to do with, I never found a good family practice that wasn't like, either heavily Medicaid or, and I was, I did work for a company called Cool Smiles for a while in Massachusetts. Actually, I was really happy with that, even though it was corporate and DSO. I like that, but then I moved here and I wasn't doing it anymore. And then some things happened with Cool Smiles that weren't that great either later. But for me, my experience as an associateship were very poor in terms of like I didn't like how the offices were managed. I felt like I was being completely gypped, to be honest, in pay. But I know there are good associateships out there. So it depends on what you find. I just felt like I kept hitting the wall. I couldn't get into a good practice. And I personally felt like there were there were good practices out there, but they had connections with, other dentists, and that's how people got in. And that's one thing that I would highly advise. I should have put it in here, but this is a good question, because I highly advise that you build a relationship with professors or other dentists or a community that can help you get an in on a good associateship, because that's one thing I was truly lacking on. It was my kind of personality back then to be like all in one. Like I never wanted to get anybody's help, even in dental school. Like I had one friend and I studied with her, and I highly suggest that you don't do what I did, and you build connections and you network and you do that. I just wasn't good at that, and I wasn't trained in that. And yeah, I wish somebody had advised me to do that more, because I think that's how you find a good associateship. So that's why, again, because of my personality, I just was like, okay, I'm going to do this myself and I can do it much better. And thankfully it worked out. And I'm happy with my practice, and I won't regret it. I don't regret it. I never go back to, hopefully I'll never have to go back to associateship, but that's just my personality. I like to do things my way, and I'm very strong-headed, and I'm a risk taker too. So it was good for me to do this. But I don't think it's for everybody. I think it is a lot of work, and there's a lot of heartache that goes into it. There's a lot of blood, sweat, and tears. And, my husband, 5 years ago, he would have told me you need to not do this anymore, because at sometimes it was unhealthy. But what really helped me kind of become happier as a practice owner was during actually the pandemic, when I had, I was able to provide emergency care, and a lot of patients were just very appreciative. And I really learned how valued I am in the community. And then when we reopened, it's just been a plethora of patients and love, and tons of new patients. And it's just really rejuvenated my belief in having my own practice and belief in myself. And I think that's a hard thing to come to sometimes. Some people are really confident, but just for me, it took the pandemic for me to become confident again. So, but yeah, I think, I hope that answered that question.
Yes, definitely. Okay, so the next question is, can you explain what you mean by a bad bite? I think this is in reference to one of your cases. How does it wear the teeth out and cause them to fall out in old age? Thank you.
Yeah. So I have a patient that we just saw the other day, and she's had she's I think almost 80 now. And 80-year-olds these days, they're feisty, and she's fully living, right? Except for her teeth. So she's had a deep bite, which is when your top teeth overlap. When you bite down, you don't see your bottom teeth. Your top teeth are overlapping so much. When you bite, you should see some of your bottom teeth, right? So a deep bite is it's fully overlapping. And that, so we've been trying to maintain her deep bite for a long time, and it's caused so much wear. So basically the bottom teeth have been indenting into the top teeth for so long that it's actually caused a huge loss of the back of the top teeth. And so now she has decay in those areas where it's worn away, and the decay is so far up that it's under the roots. So it happens differently for different people. Literally, it will just wear your whole tooth away and you'll have no tooth left, or you'll wear away the enamel and your teeth will become sensitive. And then the dentin, which is, you guys know that the outer part is enamel. Then there's dentin, and then there's pulp. So if you wear away the enamel and the dentin is exposed, it's a much more susceptible part of the tooth to decay and sensitivity and pain. So either you wear it down to the point where it becomes painful and you need multiple root canals, or you literally wear your tooth away to the point that you can't fix it anymore. And you end up having to extract it. So this woman that I'm talking about, we've been trying to just patch things up for a while. She never wanted to do braces. I don't think she can anymore because she only has the front ones left, by the way. The back ones, she has like a couple implants, and the other ones she has like one molar here that she bites against the gum. So if she had, aligned her teeth and her bite corrected the deep bite, maybe when she was 30 or 40, maybe she wouldn't have had these problems. Maybe her, the wear and tear wouldn't be that extensive and she could keep her teeth. But now she went to see Dr. Zeidel, and she has to basically extract her teeth and do like a full mouth prosthesis. So it doesn't happen overnight. It doesn't happen in even 5 years, but it happens over time. And I see it all the time in our older patients.
Okay, thank you so much, Dr. Mohammed. That's all the questions we have for today. You guys, make sure you guys follow her. Her Instagram handle for her office is shown on the screen. And thank you so much again, Dr. Mohammed. Sorry, I keep on interrupting.
Thanks for all of you who joined and are following. I got like a whole bunch of new followers, so I hope to share more over time. But yeah, thank you guys. Keep up the good work.
Great, thank you so much. For everyone that's wondering about the quiz, the link should be on our link tree. You can also find it on our GroupMe. My helper, Dia, will go ahead and post that. If not, I'll get to it after I end the stream. But thank you so much, everyone, for tuning in. Thank you again, Dr. Mohammed, and I hope you all have a great night.